Hello, hello, sound check. Hello, hello, sound check. Hello, sound. Hello, hello, hello. Hello, hello. Hello, sound check. Hello, hello.
Good morning, everybody. It's my pleasure to welcome you all on behalf of API Bengal branch in our midterm 2002. Our very dynamic secretary as well as the organizing secretary of this program, Professor Partho Sahay Karmakar, to address you and start the process. Thank you.
Thank you, Chairperson, sir. Good morning, and it's a very pleasant moment that we organize our midterm program that is going to be held each and every year. Occasional inclusion of 30th April. And this is pleasant moment because after long 3 years, we are being able to hold this program physically. Last physical program happened to be in the year 2019 under efficient guidance of Professor M.K. Roy and Professor Shibendu Ghosh. After that pandemic menace, that is COVID-19, affected us, and that stepped in globally in 2020. Until 2020, because of lockdown, not in India, but in many countries of the world, we had to cancel that program. And in that early months, we didn't have any ideas. Many of us didn't have any idea to hold program virtually in Zoom. So we had to cancel it in 2020. Now came 2021, when the pandemicity was in full swing, and we arranged it in last year, 1st May, virtually. Stepped into 2022, when luckily, by the grace of God and with our sincere effort, the pandemicity is now controlled. So we have ventured for organizing this thing physically on 30th April and 1st May of this year. So that's why it's a very pleasant moment for all of us that we have come closer to each other. Ultimately, we have become physical so far our academic country is concerned. So here, I welcome you all, and I am very much thankful from core of our heart, on behalf of API West Bengal chapter, to be very, very thankful and express my gratitude for coming over here and to be present over here to listen to the topics physically and going to be active participant in this academic extravaganza for 2 days. So we have planned, we all together collectively have planned and have brought forward so many medical issues that will definitely cover topics from bench to bed. And as well as we have kept exciting clinical cases, quiz, as well as sessions. All these three are competitive. I think all of you will definitely enjoy these programs and you will participate actively. With these short introductions, I like to go to the academic program today, and we will start the proceeding right this moment. Already we are 20 minutes late, so I will definitely request all the speakers to please stick to the time. And the first session is update on rheumatology. And we are very much thankful to our guest speaker that will be introduced by our chairperson, sir, all the way from Assam to Kolkata, in spite of their own program in Assam today and tomorrow. So I like to invite Dr. Professor Udas Ghosh, Professor of Department of Medical College, Kolkata, to be on the podium, as well as I request another professor, Professor Dr. Parth, Department of Medicine, National Medical College, Kolkata, to be on the podium. I request both of you to start the proceeding. Over to you, sir, Dr. Partha Sarkar and Dr. Udas Ghosh, sir.
Okay, good morning, ladies and gentlemen. So this is the first session, and I have I sincerely thank to the organizing committee, especially the secretary, chairperson, and scientific chairperson, to invite us to chair this session. And in the opening session, our speaker will be Dr. Pradeep Kumar Sharma. He is from Assam. He is a good friend of ours. He is very much well known to this part of the country, along with in the national forum. We have the pleasure to have him. And he is MBBS medicine from Assam Medical College, DM Rheumatology from SGPGI, received Japan College of Rheumatology Fellowship in 2007, worked as assistant professor in Guwahati Medical College till 2012, HOD Department of Rheumatology at Apollo Excel Care Hospital, Guwahati. Total publication 30 as of review article, abstracts, and book chapters. He is ex-editorial board International Journal of Rheumatic Diseases and secretary of Indian Rheumatology Association, Assam chapter. He will talk management of psoriatic arthritis. Just 1 or 2 lines about psoriatic arthritis. It is a very complex and heterogeneous disease. And over the last 10 years, there is enormous change in the management of it. Last 5 years, almost 6 new therapies have come up. And there is no typical flowchart, no typical guidelines, as there are so many domains in psoriatic arthritis, namely muscular skin, some extrarticular manifestations. For each domain, there is some drugs are better, some are not that better. So there is so many recommendations from so many bodies. So I think Dr. Pradeep Sharma is the best person to tackle all this and give you an overview and a very compact information regarding management of psoriatic arthritis. So over to Dr. Pradeep Sharma.
Thank you so much. My respected chairpersons, my respected teachers, seniors, and my friends. It's indeed an honor for me to be part of this API Bengal midterm. And I'm really humbled by the hospitality shown by the organizing committee, especially Kormakar sir. So, psoriatic arthritis is grouped in spondyloarthritis because along with ankylosing spondylitis, arthritis, IBD-associated arthritis. They are grouped together because they share some common clinical features like inflammatory back pain, involvement of the large joints of the lower limb predominantly, then inflammation of the side insertion of the ligaments and tendons, which we call as enthesitis. They have common radiographic features like sacroiliitis and syndesmopathy formation, and they have some common extra-articular manifestations, or inflammatory bowel disease, then common genetic factors like HLA-B7 positivity. But since last 1 decade or so, a debate is going on whether psoriatic arthritis should be lumped together in this group or it should be splitted. Because psoriatic arthritis can have a variety of presentations in the joints, and spondylitis is just one type of psoriatic arthritis. We'll come to that later on. Then involvement of the musculoskeletal system, as our chairperson sir has also already mentioned. There can be dactylitis, there can be enthesitis along with joint involvement or along with back pain, that means axial disease. And there can be various combinations of all these features. But psoriasis is not just involvement of the skin or joints. Because obesity is common in psoriasis patients, then along with obesity, cholesterol and cardiovascular disease is increased because of the component of metabolic syndrome, or because of the inflammation itself is a risk factor for cardiovascular disease. Because of the involvement of the joint, involvement of the skin, these patients are and anxiety. So it is not just skin or joint disease. There are many in psoriasis or psoriatic arthritis. So if you look at some of the meta-analysis, then compared to general population, psoriasis or psoriatic arthritis patients are more obese. Then there is diabetes, hypertension, dyslipidemia, diabetes. These are more common in psoriatic arthritis patients than general population. So this was a meta-analysis of words, and we can see cardiovascular mortality, infarction, stroke. These are more common in psoriasis than in the general population. Psoriasis prevalence in the society is around 1 to 3%. And among psoriasis patients, the prevalence of arthritis varies from series to series. Up to 1/3 of the patients of psoriasis can have arthritis. May be affected is 30 to 50 arthritis. Even children can be affected. In 2/3 of the patients, skin manifestations come first, then the joint manifestations. But in 20% of the patients, these can come together, and is comes first, then comes first, then only come the skin. The most common, there are various types of psoriatic arthritis, so that's why the debate whether it should be lumped in spondyloarthritis or it should be splitted. So most common is asymmetric oligoarthritis or monoarthritis. Around 2/3 of the patients have this type of arthritis. Symmetrical polyarthritis, like that of rheumatoid arthritis, occurs in around 5 to 20% of the patients. DIP, distal interphalangeal joint predominant arthritis, occurs in around 10% of the patients. Then spondyloarthritis variety, that is axial disease, occurs in around 5 to 20%. Arthritis mutilans, where deformities actually occurs very rapidly. Fortunately, that is rare. So recognition, how we recognize psoriatic arthritis? Actually, there is no laboratory investigations which can cleanse the diagnosis of psoriatic arthritis, like say rheumatoid or anti-CCP we can use in rheumatoid arthritis, but in case of psoriasis, there is no lab data. There will be high ESR or CRP markers of inflammation. So mostly the diagnosis is based on history and the clinical examinations. Radiology, like especially musculoskeletal ultrasound by experts, and MRI is helpful in diagnosing early diseases. So nail disease is actually very important in case of psoriasis. Psoriasis patients which have nail changes, they are more prone to have psoriatic arthritis. So nail changes can be very prominent, like onycholysis or even onychogryphosis. But we have to recognize the subtle changes like nail pitting to diagnose psoriatic arthritis early. Then this is for the PG students how dactylitis looks like. Whole digit is swollen, it appears like a sausage. Then the enthesitis now is regarded as an organ that is called as enthesial organ. Basically, inflammation at the insertion site of the ligaments and the tendons. So common sites are plantar fasciitis, retrocalcaneal area, insertion of the patellar tendon, then golfer's elbow or tennis elbow. But there can be other sites also, like tenosynovitis in the dorsum of the feet and the hands. So this is the Caspar criteria, but we have to remember that this is classification criteria. So classification criteria and diagnostic criteria are different. So in rheumatology, most of the criteria are classification criteria. These are not diagnostic criteria. So patients to label as psoriatic arthritis in the bedside, they need not fulfill the classification criteria. But I have put this one to show that history is very, very important, especially for the PG students. So history of psoriasis in the patient himself or herself, or family history of psoriasis. In any case of joint pain, always we should remember to ask about the history. Then history of dactylitis in the past, that is also can be included in the clinical criteria. Unlike rheumatoid arthritis, where we see only erosions, in psoriatic arthritis or spondyloarthritis, we can see juxta-articular new bone formation. So that is also gives us clue about psoriatic arthritis, even when there is no skin manifestations. So how we differentiate? Because like say osteoarthritis, that can involve the distal interphalangeal joints. So psoriatic arthritis also involves the distal interphalangeal joints. So how we differentiate this psoriatic arthritis from other diseases, apart from skin manifestations and nail manifestations? Like enthesitis, dactylitis, these are clues to diagnosis of psoriatic arthritis. Then in case of osteoarthritis, there can be stiffness, but that is only for a brief duration. In case of psoriatic arthritis, morning stiffness is very, very significant. It lasts more than 30 to 60 minutes. In fibromyalgia, there can be pain in the entheses or in the joints or in the back, typical of any kind of spondyloarthritis. But though patient may complain of subjective swelling, on clinical examination, there won't be any swelling in joints or in the enthesitis. Then gout, especially chronic gout, that can mimic psoriatic arthritis because it can have enthesitis, it can have dactylitis, it can have this. But in chronic gout, involvement of the back is very, very rare. But in case of gout, history is very important because in chronic gout, patient may not volunteer it. There will be always history of recurrent pain. So gout starting as a polyarticular disease is very, very uncommon. Initially, there will be history of recurrent joint pain involving one or two joints. Later on, patients develop chronic gout. Then ankylosing spondylitis, again, enthesitis and dactylitis is not that common as it is common in psoriatic arthritis. Then polyarticular psoriatic arthritis, how we differentiate from rheumatoid arthritis? Again, enthesitis and dactylitis are common in psoriasis. It is not found in rheumatoid arthritis. Then involvement of the spine. Rheumatoid arthritis can involve the cervical spine, but it does not involve the lower back, lumbosacral spine. Then uveitis is a feature of psoriatic arthritis, but rheumatoid arthritis we see conjunctivitis or scleritis. We need to diagnose psoriatic arthritis early. Why? If we see in the curve, within 2 years, half of the patients have more than one erosions. So erosions means deformity later on. So within 2 years, half of the patients will have at least one erosions. And by 10 years time, more than half of the patients have 5 or more joints deformed. And it is not like that ultimately patient will have, later on the disease will burn out. If we don't treat them properly, this disease relentlessly progress, and later on there will be severe pain and disability. And if the inflammation is not abated, there will be more risks of cardiovascular diseases. So that's why we have to recognize psoriatic arthritis early. So the dermatologist has an unique opportunity because we have to give them this message, because in 2/3 of the patient, skin manifestations come first, then only the joint manifestations. So there are various questionnaires, but I always request our dermatologist colleagues that in psoriasis patients, they should always ask the patient whether he has or she has any kind of pain. If there is any kind of pain in a patient of psoriasis, we should be always looking for psoriatic arthritis. And if they are comfortable with treating psoriatic arthritis, it is okay. If they are not comfortable, better to refer to a physician or a rheumatologist. So what are the contributing factors for psoriatic arthritis? So there is a genetic background. HLA-B27 is common in spondyloarthritis varieties, but there are various genes in other varieties. Then both innate and adaptive immunity is involved in psoriatic arthritis. Then environmental factors like infections, viral infections or bacterial infections can trigger development of psoriatic arthritis. Trauma, what we call as Koebner phenomenon in case of the skin. So that can be also a factor in psoriatic arthritis. The Koebner phenomenon can be seen in skin as well as in the joints also. So sometimes patients get history that after an accident or some injury, I develop arthritis. That gives a clue to psoriatic arthritis. Then endothelium is also important, this vascular pathology. So psoriatic arthritis develops in stages. So there is a background, genetic background. Then there is a second hit, which can be trauma or comorbidity like obesities, or there can be mechanical trauma, or there can be microbiome related event. Microbiome is coming into every field of medicine. That is important in case of psoriasis also. So because of that, there is aberrant immune activation in the gut or in the skin or in the anthesis. So that leads to preclinical psoriatic arthritis. There won't be any manifestation. Then there is subclinical psoriatic arthritis. So there won't be any symptoms for, at this stage, but there can be silent inflammation. If we do ultrasound or MRI at the anthesial sites, there can be some, we can show some inflammations. Then there is prodromal stage where there is arthralgias and fatigue, but there is no frank arthritis. Then ultimately patients will develop synovitis, enthesitis, dactylitis, or a symmetrical axial disease, which we label as psoriatic arthritis. So this is the cell signaling cascade. So T cells are activated by the antigen presenting cells like the dendritic cells. Putative antigen is presented to them in context to MSCs. Then once these T cells get activated, they secrete various kind of cytokines and various pathways are activated like IL-17 pathway or ZAC signaling pathway or MAP kinase pathways that leads to activation of various cells like macrophages or basophils and leads to various kind of manifestations in the skin as well as in the joints. So these three cytokines has been found to be important in case of psoriatic arthritis, tumor necrosis factor, IL-17 and IL-23. So key features of cytokines are that they are pleiotropic. One cytokine can have many actions, and next feature is redundancy. So if one if you block one cytokine, the action of the cytokine can be taken over by another cytokines. So that's why targeted therapy like anti-TNF or IL-17 blockers is not effective in all patients of psoriatic arthritis or any kind of arthritis. So in the last decade or so, IL-17 has been found to be the key cytokine in psoriatic arthritis. So it can be secreted by the cells of both innate and adaptive immunity. And it can lead to activation of various cells and leading to various cytokine secretions. And last decades, the concept of spondyloarthritis focus has been on anthesial sites. So in rheumatoid, we see the primary site of inflammation is the synovium. But in case of spondyloarthritis, the primary site is anthesis. So what are the treatment options? So symptomatic treatment, NSAIDs, corticosteroidal injections, oral small molecules like methotrexate, sulfasalazine, leflunomide, cyclosporine, or ipilimumab. Then targeted therapy like TNF inhibitors, IL-23 inhibitors like ustekinumab, IL-17 blockers, selective T-cell co-stimulation modulator, or ZAC inhibitor. So I have 1 minute, so I won't go into the details. I will just go to the EULAR recommendations 2019. What this says that okay. So I thought I just had 1 minute, so that's why I thought I'll jump to the EULAR. So what I will just summarize, I won't take much of a minute. So according to the American College of Guideline 2018, it is very because according to them, if the patient has severe psoriasis or severe psoriatic arthritis, first line should be biological, and that is anti-TNF. But most of our patients cannot afford these biologicals. So usually we start with oral small molecules or conventional DMARDs. So that's a EULAR guideline we can follow. Probably it is more practical for us. So what this guideline says, so if a patient has polyarthritis, we have to start conventional DMARDs like methotrexate, leflunomide, or sulfasalazine. If patient has monoarthritis or oligoarthritis, we should see whether poor prognostic factors are present or not. If poor prognostic factors like structural damage, high ESR CRP, dactylitis, or non-inflammatory is present, then we have to start conventional DMARDs. Then we have to see whether patient is responding at 3 months, and patient should be at remission or low disease activity by 6 months' time. If patient is not responding, then we have to use biologicals. And if the biological is not appropriate, we can use ZAC inhibitors. But in case of enthesitis or axial involvement, conventional DMARDs has no role. We have to go for, if the patient is not responding to NSAIDs, then we have to go for biological. And in case of any significant skin involvement, we have to involve a dermatologist to treat psoriatic arthritis patients. Can we use systemic steroid? But previous EULAR guidelines says that lowest possible dose of systemic steroids can be even used can be used in case of polyarthritis. Who is biologically superior, TNF alpha inhibitor or IL-17 blockers? So we have two head-to-head trial. One is EXIT, adalimumab versus secukinumab, and they have in the polyarticular disease, most of the patients, then they had severe psoriasis. For joint manifestations, both are similar. Adalimumab and secukinumab are similar, but for skin manifestations, IL-17 blockers, secukinumab is superior to anti-TNF. A patient has severe skin disease, select another IL-17 blocker, ixekizumab, that is not available in India. Another study versus adalimumab, similar findings. So joint manifestations both are same, but skin manifestations, IL-17 blocker is better. But we should never combine two biologics, as shown by these case studies. There is high risk of infections. So to conclude, psoriasis and psoriatic arthritis are complex and heterogeneous conditions. They require individualized care. Many treatment options are available to reach remission and low disease activity. Collaborating among dermatologists, physicians, rheumatologists, and primary care can ensure optimal patient outcomes. Understanding pathophysiology allows us to better target drugs to intervene at specific points of inflammatory cascade. Thank you. Thank you for your patient hearing.
Thank you, Dr. Pradeep Sharma, for your elaborative discussion on psoriasis and psoriatic arthritis. Though the topic was the management, and he has also narrated the clinical classification, diagnostic criteria, and also the management. Some newer drugs and some biologics are available, and that is the main point of focus for the physician. So basically, it is a treatment a joint approach. It's a physician, dermatologist, and a rheumatologist. Now, this session is open for comments and questions. Dr. G.D. Chaudhary.
Hello.
I just want to know your experience which apremilast if you have used in psoriatic arthritis or psoriasis.
Yeah, before this, the generic tofacitinib was available. Most of our patients actually, after the conventional DMARDs fails, we didn't have options really. At the time, we used apremilast, phosphodiesterase inhibitor. But personally, I don't find it very effective for skin as well as the joints also. So my experience is not that great. And I asked my dermatologist colleagues also what is their experience with apremilast. They also told me that it is not very effective for skin also.
So about your opinion about the leflunomide?
Leflunomide is very good for joints, but for skin again, it is not very effective.
When you used to, rather when you, indication of this use, is a methotrexate failure or actually we start methotrexate first, then if not effective, then you switch over to leflunomide or?
Yes, sir. So first line is always methotrexate. If the patient, say patient cannot tolerate, then only we use leflunomide or sulfasalazine. But if the patient tolerates, first is always methotrexate. But now methotrexate is not effective. Now actually, previously we use leflunomide or sulfasalazine or cyclosporine. But most commonly nowadays we use actually JAK inhibitors before leflunomide or sulfasalazine.
And specific biologics for that, which are commonly used?
Commonly, if again we see if the joints are most problematic are the joints, then we usually use anti-TNF. But skin, if there is significant skin involvement, usually we go for IL-17 blocker.
I think if there is no contraindication to TNFi, then TNFi is mostly the first choice. And secukinumab, you said mainly the skin and nail. And I think also IBD, if it is associated, again, IL-17 inhibitor is most useful,
Yeah.
I think so.
Two-
And oral, if methotrexate fails, then apremilast has a chance before biologicals. I think so. Anyway, all said and done, it is a very informative and very good talk by Dr. Sharma. So if there is no more question, I conclude the session over here with proposed hand and a big clap from the audience for Dr. Sharma.
Thank you, sir. I am
Thank
really
you.
humbled. Thank you.
May I take the pleasure to stay, please stay over there. May I request our chairpersons, Dr. Professor Sarkar and Dr. Professor Bose, to hand over to hand over a small compliment as a token of respect, appreciation from our end, that is API West Bengal chapter. Please hand over another memento along with his photo. Okay, thank you. Now may I request Dr. Ganguly sir to hand over the memento for our chairpersons. Dr. Udas Ghosh. To Dr. Udas Ghosh and to Dr. Partho Sarkar. Now we pass on to our very exciting neurology session. Okay, this session has been divided into 3 sessions, session 1, session 2, and session 3. And there are so many neurologists, and that this session will be headed by Professor Biman Kanti Rai. So for session 1, neurology session, we are having 2 important chairpersons to chair that session. I take the pleasure of inviting Professor M.K. Roy, is ex-retired professor of National Medical College, Kolkata. He's having profound experience as well as knowledge in neurology. May I request Professor M.K. Roy to come to the podium and to take his chair. Now, another very astute physician, that is Dr. Jayan Sharma, attached to Apollo Grills, Kolkata. May I request Dr. Jayan Sharma to come over the dais, and I request Professor M.K. Roy and Dr. Jayan Sharma to start the proceeding. Session 1.
Okay, good morning, everybody. So without wasting much time, let us start a very fascinating session. And speaker for this session is no less than Professor Biman Kanti Rai, who needs no introduction in this forum, because at present, in the scenario of stroke, he is the main person. He is doing a pivotal role in managing stroke, especially in acute thrombolysis, and also he is a liaison officer with all the districts from BIN, and he is the ICMR project is going on under him. He has a lot of publications, and he is actively involved in managing the stroke protocol in our eastern region of this country. With these few introductions, I think we should start our proceedings. And before these things, 1 or 2 words about the imaging in the stroke and its correlates. I like to tell you that in the last decade or so, the imaging in neurology has come up in a very big way and giving us a lot of opportunities, especially in the therapeutic armamentarium. Because about the 2 decades back, with a nihilistic idea about the approach to ischemic stroke, but with the advent of various modalities, especially the CT and the MRI. MRI with diffusion weighted imaging is one of the most important things in detection of very early ischemic stroke. I think Professor Rai will be talking on various aspects of imaging, especially the CT, what to do, as well as the MRI, the diffusion weighted MRI, the perfusion images, and other various modalities which are involved in management of stroke. With these few words of introductions, I now hand over to Professor Rai for further proceedings. Over to Dr. Biman Rai.
Thank you, sir. Good morning, everybody. First of all, I express my gratitude and thanks to PI West Bengal chapter, who has given us this opportunity to share our views on stroke assessment and stroke management. On behalf of the whole neurointervention team, Bangalore Institute of Neuroscience, first of all, I want to tell you that one of the main objectives of our presentation is, as Professor Rai has already told, in last 2 decades, there has been a dramatic change in approach to diagnosis and stroke management. And the nihilism that we had regarding stroke has now changed to optimism. Because with advent of thrombolysis and stroke management. But at the same time, your interpretation of the imaging should be absolutely right. And to achieve this, you may need more time. Sometimes physicians face difficulty to trade off between these two, that is accuracy and speed. Now, when I face this situation in my clinical practice, be it in the BGOPD or in ward round, first of all, I tell myself, I am not a radiologist, but as a treating doctor, I have to ensure best possible outcome for this stroke victim. So to achieve that, I always ask myself 6 questions when I look at the images. These 6 questions are: is it a case of stroke? If it is a stroke, then what is the type of stroke? When it happened? Which vessel is involved? Artery, vein? If artery, which artery? How severe is the stroke? And what is the possible cause of stroke? I feel whenever we who are not radiologists, we interpret neuroimages in a suspected case of stroke to try to get answer to these questions, and that will ensure optimum management in a case of stroke. So first, let's start with, is it stroke? A 83 years old male patient, he presented with sudden onset difficulty in right upper limb. Within 1 hour, it involved the right lower limb, and there was slurring of speech. He is a known hypertensive and diabetic on irregular medication. This is the critical scenario. You go for CT scan of brain immediately. And the CT scan, as you can see, it is absolutely normal. Then the immediate question is it a stroke? And it is a case of stroke because the patient had multiple risk factors to develop stroke. He's elderly, he's diabetic, he's hypertensive, he's irregular medication. The problem started suddenly, and there is a focal neurodeficit. So in spite of normal CT finding, it is a case of stroke. So remember, absolutely normal CT scan is a common finding in acute stroke. As you all know, stroke is abrupt in onset, focal in distribution, measurable, and it is basically a constellation of some negative symptoms and signs. This acronym was made popular to identify stroke at public level. Whenever any of these symptoms are present, the people should be taught not to waste time. They should immediately report to the doctor to see whether it is a case of stroke. Now, when you interpret an apparently normal CT in a suspected case of stroke, you must remember there may be some early clues in the apparently normal CT. One of the important early findings in acute ischemic stroke is hyperdense MCA sign. You can look at this hyperdense MCA. It is basically a thrombus within MCA. Any radiopaque thrombus in intra-arterial circulation may be seen as hyperdense arterial site. It can also occur in the basilar artery. But remember, in some situations where there is no stroke, but they may falsely show hypertense MCA sign, like if there is arterial calcification, there is low blood flow, or the hematocrit is high. And it can be falsely negative if the CT slices are taken at a longer gap. So it can be falsely positive as well as falsely negative, but presence of hyperdense MCA sign in a suspected case of stroke is very important because it signifies a major vessel block and it signifies that the thrombus is made up of mainly by red blood cells. And in these cases, IV thrombolysis is not going to be very effective. Probably we may have to go for megalican thrombectomy. When the MCA branches are viewed in the cross section, in the Sylvian fissure, you can see it as dot. This is called MCA dot sign. This is also an early feature of acute stroke. Next important issue is loss of insular ribbon. If you look at the normal side, insula is present over here. Insula is basically a strip of gray matter. You all know in the CT scan, non-contrast CT scan, white matter looks dark, gray matter looks less dark. So there is a differentiation. Now, when the insular cortex is involved due to acute ischemia, it loses its signal. It also becomes dark. So the differentiation that is less dark and comparatively more dark, that is present on the normal side, that is lost in this side. This is called loss of insular ribbon. Basically, it is nothing but the loss of differentiation between gray and white. Insula is cortex, it is less dark, and the underlying subcortex is more dark. This differentiation is lost. This is called insular ribbon sign. And another important thing you should not miss is the hypodensity. That is a common finding in early common finding of acute ischemic stroke. And another important finding is effacement of the sulci. This is the normal side. You can see the sulci. These are black. And in between the sulci, there is gyri. Now, when acute ischemia develops, these sulci are compressed. This is called effacement of sulci. That is, the sulci which are clearly visible in the normal side are not visible in the abnormal side. So, suppose in this particular patient, if there is a history of acute right-sided hemiparesis, you can easily tell there is a evolving ischemia involving the left hemisphere. And sometimes if there is a big infarct, there is shifting of the midline. So these are some of the early CT scan finding in acute ischemic stroke. So far as the findings in CT scan in otherwise is very simple. In a case of stroke, if you interpret city, either it should be a normal city, or there is some hypodensity in the city, or there is some hyperdensity in the city. It is, if these two are there, it can be an ischemic stroke. And if you clearly see this hyperdensity, it is a hemorrhagic stroke. So interpretation of city in a suspected case of stroke is relatively very straightforward. Only thing is that you have to be aware of the early CT finding in acute ischemic stroke. Now, regarding MRI, when in a suspected case of ischemic stroke, we look at MRI, we mainly look at T1, T2, DWI, and ADC. And as you find over here, there is restriction of the DWI image. This part is bright white, and the corresponding ADC is black. So whenever you look at MRI in acute ischemic stroke, you try to find out whether there is any DWI restricted lesion and the corresponding part in the ADC sequence, whether it is black. That tells you that it is an acute ischemic stroke. And in T2, this usually looks white, and in T1, this looks black. So this is the usual MRI finding in acute ischemic stroke, and these are the imaging sequence that you have to interpret. Again, another case history. A 52-year-old male patient, diabetic, hypertensive, family history of stroke is present. He presented with recurrent left complete hemiparesis. If you look at the CT, except few hypodensities, otherwise the CT is normal. Now let's look at the MRI. In MRI, you get one DWI restricted lesion and multiple T2 hyperintensities. And some of the lesions are round or ovoid, and there are periventricular hyperintensity. So this is a 52-year male patient who presented with recurrent neurodeficit, and these lesions sometimes may mimic demyelinating lesion. And the MRI angio is absolutely normal. In this situation, when you look at the images, you always take the clinical history into consideration. The patient is diabetic, patient is hypertensive, there is a family history of stroke, and with these imaging finding, your diagnosis should be, it is a case of acute ischemic stroke. So what I want to emphasize is when you interpret the images, you not only look at the picture, images, you also keep the history of that particular patient in your mind. So clinical judgment is the most important part when you interpret the images. So first question I have tried to answer, is it a stroke? Then the next question is, what type of stroke it is? Is it infarct or is it hemorrhage? I have already shown you the picture of infarct and hemorrhage in the CT scan. And if I MRI, this is the typical picture of infarct. If I go back to MRI, had it been hemorrhage in T1, sometimes this will look hyperintense, that is white. And another image that we take help of is GRE, that would look black. So to differentiate infarct from hemorrhage in MRI, you mainly depend on two sequences. One is T1, one is GRE. In T1, hemorrhage will look white, may look white, and in GRE, it looks jet black. And for diagnosis of ischemic stroke, you mainly focus on DWI and ADC. These are the two important things you have to keep in mind while you look at MRI. So regarding the type of stroke, I think this part is clear. But again, I will go to another history. A 50-year-old male patient who presented with right-sided weakness, and he presented within the golden period within 1.5 hours. And the on-duty doctor, with a lot of enthusiasm, he thought MRI should be done first because that will give him a lot of answers. So he directly went for MRI. And this was the MRI picture. The last seen well. Suppose a patient wakes up in the morning with left-sided hemiparesis. Then what should be the time of onset of stroke? It should be at 9 p.m. last day when the patient was last seen well. Because no one knows when the stroke happened. So onset should be last seen well. Now, one of the major drawbacks of this concept is that in this situation, we may miss some cases who could have been benefited by thrombolysis or thrombectomy. At the same time, with a lot of enthusiasm, if we go for intervention like thrombolysis or thrombectomy, we may also fall into trouble. Because if the time window was really very long, then the patient will have complications. So there was a paradigm shift. From time window, they changed to tissue window. So then came the concept of penumbra and core. We all know when there is any ischemia in the brain, there is one part of the brain which is irreversibly damaged due to ischemia. This part is core. And the other part of the brain, there is some part of the brain surrounding the core which is damaged by I there is a DWI clinical mismatch. And this presence of this mismatch tells you that there must be some penumbra zone. And due to this large penumbra zone, the patient is having a huge clinical deficit. But actually, this is
salvageable. And the another mismatch that we can take help of, that is DWI flare mismatch. If you look at this MRI, DWI is black. But when there is no signal change. Suppose this patient presented to you with right-sided hemiparesis with history of recurrent TIA in last 12 hours. So now it is 12 hours. So you are in a dilemma what to do. Should I go for thrombolysis? Should I go for thrombectomy? Now in this situation, if in the flare image, if it does not show any signal change, that means there is no irreversible loss of brain tissue. So there is a DWI flare mismatch that tells you that there is still some penumbra zone and this patient can go for thrombolysis. So this is how images, particularly MRI images, can tell you about the time of onset of stroke. And this is very important when you go for specific stroke management in terms of thrombolysis or thrombectomy. Another issue is we can also tell the age of the infarct. Suppose you look at this CT. In this CT scan, this is a hypotenuse lesion. This is also a hypotenuse lesion. The hypotensity in this side is more compared to the hypotensity. So I can tell this patient has multiple infarcts, but these infarcts are of different ages. So that tells me that it is the case of recurrent stroke. So CT scan can also tell you the age of the infarct, and this can be very clearly told in case of MRI. In this particular patient, if I look to the T2 weighted image, there are multiple T2 hyperintensities. So there are left-sided hemiparesis. So images can help you in decision making of treatment. Images can tell you about the age of infarct. Next important issue is what type of vessel is involved. Is it an arterial stroke or a venous stroke? Now look at this case history. A 27-year-old female patient, childbirth 3 days back, presented with a history of headache for 7 days, followed by slurring of spleen for 1 day, and this was followed by recurrent convulsion and progressive drowsiness. This was the history. Now look at the CT scan. There are multiple hypotensities on both sides. There are some hemorrhagic lesions on both sides. So what should be the diagnosis? Is it arterial stroke or venous stroke? The diagnosis should be venous stroke. The important clues in diagnosis of venous stroke is it is bilateral involvement, there is early hemorrhagic component, and most important, it is not following any arterial territory. There is gross perilesional edema. And sometimes, if you carefully look at the CT scan, you can get this hyperdense thrombus in the distribution of the venous sinus. So venous stroke should be suspected whenever you get stroke-like lesion which is not following any arterial territory. When there is early edema, severe edema, and when there is hemorrhagic component. And going back to our case, this was a case of extensive venous sinus thrombosis, and you can easily appreciate this diagnosis is very important because treatment in terms of heparin or low molecular heparin or conventional heparin may be very much rewarding. Now, if the ischemic stroke is due to arterial stroke, then I should try to get answer to this question. Is it a small, medium or large vessel? And which artery is involved? I'm just showing this picture because as you know, these are all large size artery. These are the small arteries, and from here the lenticulostriate branch, these are small size artery. Any of this arterial distribution. Now, if you just carefully analyze the history and look at the image, you can get all these answers. Suppose in this patient, there is a DWI restricted lesion in internal capsule, left side. This is supplied by lenticulostriate artery. And the patient presented with hemiparesis, facial weakness, these are here. So it is a small vessel stroke, lenticulostriate branch, MCA. And this was the presentation. Now, if you look at this stroke, you can see a major part of the left MCA artery is involved. And obviously, this area tells you that it is a MCA stem occlusion. According to the patient presented with hemiparesis and global aphasia, because both frontal and temporal lobe was affected. Another patient presented with facial weakness and non-fluent aphasia. And as you can see, only the frontal part is involved. So this must be a cortical branch occlusion, superior division of the MCA. This is a medium-sized vessel. And look at this picture. Here, mainly temporal lobe is affected and patient presented with fluent aphasia, field defect. So it is again a medium-sized inferior division MCA. And if you look at this picture, parasagittal area, which is supplied, affected, and patient presented with limb paralysis, lower limb paralysis, urinary incontinence, and great apraxia. So this was the case of anterior cerebral artery stroke. And if you look at this distribution, thalamus is paired. So only the posterior cerebral artery P2, that is peripheral part, is involved. And if you look at this part, not only the occipital, the thalamus is also involved. So the proximal part of the PCA is involved. So the three things are important. You look at the picture, which anatomical structures involved, which artery normally supplies the structure, that tells which artery is involved. And once you know which artery is in medium side, small side, and you always correlate this MRI finding with the clinical history. That is sufficient. You did not know anything more, you did not do anything more. But this part is very important. A lot about the etiology of the stroke. Presented abortion hemiparesis, this was a P1 segment of PCA block. Facial weakness, abortion, contralateral hemiparesis, it is parapontine perforator. These are the small vessels from the basilar artery. And you can see the lateral medullary stroke over here, and also there is involvement of the cerebellum. This is the classical picture of pica territory stroke. And this picture you should keep in mind, because sometimes this is the classical presentation of internal capsule stroke, contralateral hemiparesis, hemianesthesia, hemianopia. But remember, not all patients with this presentation have stroke in the internal capsule. This can be a presentation of anterior choroidal artery stroke. This is the classical MRI picture of anterior choroidal artery stroke. And this is the another important findings is the watershed zone infarction. This part I will show you later on. Suppose it's another case, a patient presented with recurrent left-sided limb shaking TIA for last 3 months, and this time he has presented with left hemiparesis for, and this was almost normal. If you look at MRI picture, there are some infarcts. And you have to be very careful about the distribution of these infarcts. One is in this area. This is the border zone between anterior cerebral artery and middle cerebral artery. So this is called a watershed zone infarct. And there are some infarcts in the white matter, which is above the level of lateral ventricle. That is called centrum semiovale. And this is again an watershed. There are two watershed areas in the brain. One is cortical watershed, that is the watershed between anterior cerebral and middle cerebral and posterior cerebral. This is another watershed. These two are cortical watershed. And there is another watershed that is called subcortical or deep watershed, where there is watershed in the superior and the deep branch. And this is that side. So this is a stroke in the classical watershed distribution. This time he has presented with left-sided hemiparesis, but prior to that, he had recurrent TIA. And what I told, this is the pictorial description, and these are the watershed. This is one watershed. These two are superficial watershed, deep watersheds. So these are the typical pictures of watershed infarct. I am showing you this picture because whenever you get watershed infarct, you always suspect this can be a large vessel occlusion stroke. Why you need to know it? Because the LVO strokes, initially they present with very mild clinical manifestation. And that usually is in the form of recurrent TIA. But after a few days, they present with devastating stroke. What is important, as a doctor, you identify, you suspect this is going to be a case of LVO stroke. In that case, you immediately go to angiographic studies, and if necessary, you may have to go for thrombectomy. That will save the patient. That will save the patient from mortality as well as severe morbidity. So this identification is very important when you look at MRI or CT. In this case, practically in this side, there was no internal carotid artery visible. I am telling case history of another patient. That was a 55-year-old male patient, diabetic, hypertensive, presented with transient weakness of either side of the body, lasting for less than a few seconds. And if you look at the MRI, you can get multiple watershed zone infarct. In this situation, you suspect this can be a case of large vessel occlusion. Your immediate next investigation should be MRI angio. And you can see bilateral ICA occlusion. So this message is very important because unless you suspect watershed zone infarct, you will miss large vessel occlusion. This is very important. And one or few words about venous stroke. If we suspect venous stroke, then again the question is it a superficial vein or a deep vein? This is a case of ours in OPD. It's a 45 years old male patient who presented with and if you look at the MRI T2 picture, they are involving both basal ganglia and thalamus. There are so many differential diagnoses. But once you look at this picture, it tells these are definitely vascular problems. And whenever you see like this, you always suspect the possibility of deep cerebral vein. In fact, this is the classical presentation of deep cerebral venous thrombosis. This is the classical T2 picture of deep CVT, and this is the classical imaging findings, angio findings of deep CVT. And in case of superficial cerebral venous thrombosis, you get bilateral. I have already shown you bilateral DWI restricted lesion. ADC may look black, T1 it looks black, and you look at the GRE, there are multiple plots. So I have already told, and this is the classical picture of sinus thrombosis. So we have noticed that stroke issue is how severe is the stroke. The most important fact about stroke is that you cannot hide the severity of stroke. It can be assessed clinically by NIHSS scale. It can be assessed radiologically by aspiration. And it can be assessed functionally by MRI scale. So stroke is, and you have to measure it. NIHSS scale, I am not going to details. Regarding the radiology part, if you look at the this is a topographical score in S score, there are total 10 taken at 2 levels. This is for ganglion and another is the supraganglion level. This is lentiform nucleus, this is internal capsule, this is insular. 1, 1, 1, 1, 4. So this is the ganglionic level. And at this ganglionic level, the anterior part of the cortex M1, on lateral to the insula is M2, and in the posterior part M3. And the corresponding cortical area in the supraganglionic level is M4. So if there is a coded that is 9. If suppose the patient has hypotensity in the caudate, lentiform nucleus, then a capsule and insula, from 10, the total potential will be 6. So by that way, you calculate the aspect, and the less is the aspect score, the worse is the outcome. In fact, if the aspect so aspects tells you about the severity of stroke and also guides you whether the particular management is going to be effective or will have some major side effects. Minal, the time hole bolna
Sir, it's already 1 minute left, sir.
I complete kore dicchi. And regarding the, abhi 2 minutes hoye jabe. Regarding the cause of stroke, we classify whether it is a large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology or undetermined. Now, all these answers you can get, I have already discussed from the imaging finding. So this will also tell you about the cause of stroke. And at the last 1 minute, I am just showing you with severe around 10 days after it was a headache, started within 7 to 8 hours and was associated with vomiting and photophobia. 5 days, she again had similar type of headache, unconscious, and had decided paralysis. So angio was repeated, and this time it was completely normal. So this is a case of reversible cerebral vasoconstriction syndrome. So when you diagnose or when you suspect this type of cases, you always keep the clinical history in your mind, because this was a young patient. She had no known risk factors of stroke. She was in the postpartum period. She presented with thunderclap headache. So don't forget to repeat the MRI angio once you get this type of occlusion, because that can tell you whether it is a case of RCPS. So the take-home message is identify early, assess severity, vessel affected and possibility, eligible candidate. And next, focus your attention on secondary prevention. Thank you very much.
Thank you, sir. Thank you for nice deliberation and a lot of good pictures what we have been seen. So if any questions from the audience, please ask to Dr. Roy.
This one is absolutely normal. Actually, some university after 24 hours, some say after 14 hours repeat CT scan or MRI. Which do you like, MRI or repeat CT scan or 24 or 48 hours?
If after 24 or 48 hours, I go for repeat imaging, if I have the facility of MRI, then obviously MRI is a better choice than CT. But what I want to emphasize in acute situation, when you are to take regarding thrombolysis or thrombectomy within the window period, in that situation, in most of the cases, not always, CT is a better investigation than MRI because first of all, it is widely available. It takes less time. And in addition to non-contrast CT, if we do other modalities, can have a lot of. But after 24 or 48 hours, if you want to repeat imaging, and if you have the facility, obviously MRI will tell you much more than CT.
I'd like to know what is the duration from clinical stroke to appearance of imaging finding? What is the duration?
Sir, regarding the imaging abnormalities in CT scan, the hyperacute CT scan changes that I showed, they can appear as early as 1 hour after onset of stroke.
1 hour.
Within 1 hour. CT scan. MRI DWI restriction that can appear even early.
MRI diffusion you can get within 10 minutes. In CT you can get within half an hour to 1 hour.
What is the imaging finding in case of TIA?
In case of TIA, there are two definitions of TIA. One is time-based definition, that